We close this section with JeanPierre Lin. I think everybody knows him. He's one of the most expert on pediatric movement disorder and DBS from the Evelina Children's Hospital. So, up to you.
Thank you very much, Giovanna, and thank you very much to the organizers of this magnificent conference, and thank you to all the participants. Just before I start, I'd like to know how many in the audience are actually family or family members or relatives. Just put up your hand, because one of the things that I want to do is to help you to navigate what must be the whitewater rafting of living with a child with a GNAO1 movement disorder. Now, I hadn't thought of using the top pictures very much. There's no pointer, but you'll see that there are two little pink infants who are evidently dyskinetic. They have fisting, posturing, and if they were movies, they would be constantly on the go. And we know that infants do this, and you have all done it as well. So there's nothing mysterious about the biology of dystonia. You've all had developmental dystonia, and developmental dystonia responds to some simple things: love and attention, swaddling and cuddling, and sleep. When the baby's asleep, you pick up the arm, it just flops down, you can tiptoe downstairs and have your dinner. But when the child is awake and fretful, that dystonia comes back. Now, in black, that is not a newborn infant. That is a 5-year-old child with dyskinetic cerebral palsy. And with that child, maybe handling, swaddling, cuddling, attempting to seat them won't help to switch that off, and maybe sleep won't help to switch it off because they can't get to sleep. So I want to sow the seed at the moment that sleep physiology and the diurnal cycle is a very important component in preventing the system from getting out of control. Now, one of the problems about this field is the early onset nature of childhood movement disorders. The majority are early onset. And so it's quite difficult to use the timing of onset of the movement disorder as an important variable. But what we do know is that the more severely affected are the most early affected. So that's one thing. Oh. Okay. Now, most of the conditions that we think we're looking after are in fact acquired. But what we realize is that the orange zone, which represents 2/3 of the cases, actually, perhaps 20% of these cases will have normal scans. So if there's no damage on the scan, what have they acquired? And then the question is, how many of those are actually going to have a genetic disorder? And what we've found recently is that the more you search, the more you find genetic abnormalities that represents a new part of the spectrum of childhood movement disorders. And they behave differently from the classical cerebral palsies. And when we look at the partition of the dystonia cake, we've been previously impressed by the DYT1 cases, the DYT11 cases, and what we now find is that there are new kids on the block who maybe are going to expand, and we find that our cohort of GNAO1 cases is expanding quite rapidly and will probably overtake some of the other types of genetic disorders that we thought were the predominant type of genetic disorder. So that cake slice is going to change, and with that there's going to be growing interest and support for the GNAO1 cases. But it also means that clinically we are more attuned to suspecting who's got a GNAO1 problem. And so if you have a child that presents with a severe dystonic choreoathetosis and can't sleep, then you should strongly suspect that this is a GNAO1 disorder. Now, I've put GNAO1 here in the orange oval to show how early onset it is. But as we now know, there's the late onset GNAO1 that do behave differently and don't really fall into the same category of severity. Now, these three cases seem to have a similar phenotype because they've got a severe cervical dystonia, they've got scoliosis, and they have difficulties with their postures. But in fact, only the middle one is going to move in the video. And she doesn't have GNAO1, but you could easily have GNAO1. And so we know that the GNAO1 phenotype and the KMT2B phenotype and the FAP1 phenotype share a commonality. So we've all been dystonic, and there are lots of genetic dystonias that resemble each other. And this is a list of our current known GNAO1 cases, and I've put it together to actually demonstrate which of these cases has had status dystonicus. And you'll see in red here that the majority of them have had status dystonicus. And of those cases, at least 2 have had what I've termed cappuccino mouth, so we're in Italy. And cappuccino mouth is when the tongue is whipping around so furiously that the saliva forms a stiff foam around the mouth. When that happens, you know that you must seek help. But it's something that doesn't happen in the later onset cases in blue that I've highlighted up there. And the other aspect of the susceptibility to going into a dystonic crisis is the earliness of the onset. So in the top group, you find you have delayed development as the early manifestation, followed by a later onset of dystonia. But you'll see that in case number 3, this is a girl who was admitted to our unit from an intensive care unit in Manchester, and she had a dystonic crisis around about the age of 8 or 9, much later than would be anticipated from the other cases in red. So this is one of the later onset cases. We didn't know that she had GNAO1 because we only discovered that in 2018. But you'll see that she is having a neuropsychology assessment, and it's difficult for her to perform the task because of the hypermobility, hyperkinesia of her trunk. She hasn't been able to go to school for 2 years, so her activity and participation has been very much restricted. She's an intelligent girl. She has some learning difficulties, but she is able to perform, and we got through her a neuropsychology assessment. And I would say that although she's sitting, her sitting quality and ability is actually limited, so that very soon after starting the test, she had to be taken out of her seat, and you can see she's extended in the seat, so it's a very uncomfortable position, and the psychology test had to then be performed lying down. So one of the concepts I want to illustrate is that difficulty with sitting is a red flag. If a child has been able to sit and then they enter a phase where they find difficult sitting, then that's beginning to show that the dystonia is increasing and needs to be helped. And here on the left-hand side, she's doing some work with our occupational therapist. She's determined to do it. Her neck and spine don't want her to do it, but she's going to do it anyway. And then she has her DBS, and you can see that the sitting is controlled. She can pick up her pencil, and in the bottom panel, She's going to do that with her left hand, which could be a big dystonic drive, but isn't. And she can do that. And so sitting comfort is the first hallmark of something that's going wrong. Lack of sitting comfort, sorry, is what I mean here. Now, these should move, but they don't move, but it was just to illustrate that she was able to walk afterwards, but she had a fixed hip flexion deformity, so she still had to walk like this because her hips were fixed in this position. But still, she became mobile after she got her deep brain stimulation. So how to recognize the severity of acute dystonia and deterioration and plan medical and surgical management? Well, we have to classify the dystonia severity from stable to unstable. And this is something which can be easily done by a scheme which I'm going to illustrate in a minute. Status dystonicus is an increased severity of generalized dystonia, interfering with activities and refractory to medication therapy. The etiology may be genetic or acquired, and if it's acquired, it's more difficult. However, if it's a certain type of genetic disorder like GNAO1, it's even more difficult. The immediate goals of management are to improve comfort, sitting tolerance, sleep, metabolic stability, and ease of care. But the first three are the key to achieving the last two. There's no consensus on the timescale or how long you have to be in the condition for it to be a serious problem. When it comes to who should be able to recognize status dystonicus, well, parents and carers, teachers, nurses, and doctors. So it should be simple for people to realize when this is happening. So we developed a scale called the Dystonia Severity Action Plan. We had 20 or 30 clinical scenarios. We asked a whole group of carers, healthcare professionals, pediatricians, neurologists, disability consultants to analyze the scenarios and to score them. And the scale is simple and rewarding to use and helps you to understand where your child is in the scheme of things. Because you can have a severe dystonia child or adolescent who's sitting comfortably, sleeping well at night, and is not in status dystonicus. That doesn't mean they don't have severe dystonia, but they are safe. So this is how it goes. There are 5 grades. Grade 1, the child sits comfortably, has regular periods of uninterrupted sleep, and the child is stable on medication. This child does not need an assessment, and you can continue at home or going to school as usual. And if you are recovering in hospital, you can be discharged home in this condition. In grade 2, the child is irritable and cannot settle. The dystonic posturing interferes with sitting activities, and the child can only tolerate lying episodes. So this is bad because it suggests that there may be a further deterioration and slipping into the grade 3. Now in grade 3, the child is not able to tolerate lying and is unable to get to sleep or is sleep deprived. And this requires urgent hospital review and adjustment of medication or the implementation of an emergency plan, which has already been established because this has happened before. Now, until this happens, emergency plans don't tend to be thought of, but once it happens once, then the emergency plan should be utilized if and when the child's sleeping pattern is interfered with and interrupted. And of course, the thing that we all want to avoid is grade 4, which is early multi-organ failure with fever, with a metabolic disturbance, breakdown in muscles leading to rhabdomyolysis, and poisoning of the organs with the muscle breakdown products. So that's level 4. And then grade 5 is the multi-organ failure is such that you have pulmonary, renal, cardiac failure, you've got blood clotting abnormalities, and this is a medical emergency that requires intensive care and so on. And so, thinking about this, in grade 1, you have a normal lifestyle, yes. You're tolerating seating, yes. You're tolerating lying, yes. And you're sleeping at night, yes. In grade 2, you don't have a normal lifestyle, you're not tolerating seating, but you are tolerating lying and sleeping. In grade 3, no normal lifestyle, no sitting, no lying, and no sleeping. And you might start to be unwell in some way. Grade 4, all of the above, and you are starting to sweat, you're feverish, you're not feeding, you're vomiting. And in grade 5, it's the whole lot. So I've tried to illustrate how much time do we have in each phase. Well, this clicker doesn't work always, but oh. I have to point it at the screen. Okay, yeah, okay. So in grade 1, you have months to refine your dystonic plan. If you have difficulty sitting, then you should consider using the emergency plan that you have, or consult your medical team with an outpatient appointment, and that may be weeks to sort that out. But once you stop sleeping at night, then you have to get into hospital, be assessed, and have a thorough review of provoking factors and have that corrected. And of course, as soon as you're needing high dependency unit or intensive care, you have very little time before you have a proper medical emergency with multi-organ failure. So in essence, the dystonia urgency is inversely proportional to the severity of the DSAP. In other words, you have less and less time the more severe the disorder. Talking of which, I'm running out of time. I have a few more minutes, so it's just going to allow me to take you through an elaboration of how the DSAP has been used, if you like, in a real-time home emergency department scenario. So in this scheme, I'm going to present two cases here. They seem to have an axial dystonia, but one of them is in level 2, or DSAP 2, and one is in DSAP 5. And why is that? Well, because case A has a moderately severe BFM-DRS, cannot sit in the chair, that's why she's in level 2 DSAP, but sleep is preserved, so she's safe. She's not going to melt down her muscles and cause metabolic crisis. She's on 6 drugs, she's vomiting and retching, life is miserable, and she's been like that for 18 months. But she's not in status dystonicus. Whereas case B, she's got the maximum score, she can't sit in the chair, she can't sleep, she's biting her tongue, and she's on 3,700 micrograms of baclofen per day, which is a pretty high dose of intrathecal baclofen. So she is in status dystonicus. Both of them have had deep brain stimulation. One of them as an emergency, that's case B, and case A had that electively, having lived with her dystonia for 18 months. Now, hopefully we can just get to this one. So now we've got our dystonia severity action plan grades at the top, and you can all say what grade 1 is, you're sitting comfortably and you're sleeping at night. Grade 2 is you're having difficulty sitting. So you've moved from grade 1 to grade 2. That is beginning to throw up questions about what to do. Grade 3 is can't tolerate lying and sleeping is disturbed. And grade 4, you've got multi-organ failure. And grade 5, everything is going wrong. Now, the purpose of the red arrows and the black arrows is that you want to get the child back along that scale so that things are safe again. And also, you want to prevent the inevitable cascade towards a worse state. So, never mind treating and managing status dystonicus, how about preventing status dystonicus? And to prevent status dystonicus, you have to work very hard on the sleep hygiene. A child who is not sleeping well is going to be irritable and dystonic during the day, and they'll have difficulty sitting. So the key to all this is the sleep hygiene. And we know that the sleep is important because all newborn babies, if they don't sleep, they become irritable. And if they become irritable, the parents become irritable. We know that the sleep is the most important thing. So in this scheme, really, in the interest of time, the most important thing is non-respiratory depressant sleep. So yes, we go through all the usual issues about specific therapeutic strategies, particularly movement disorder medication, but as lots of people have pointed out, the movement disorder medication really runs out of steam pretty soon in this process. And so the green box is what I want to emphasize. The green box, it's not specific to, it's not a muscle relaxant that we're using. We are using something to improve sleep. And in our team, we've been using clonidine as our major method for helping with sleep, largely because our sleep disorders colleagues are using clonidine all the time to regulate sleep. And the trick is really to reduce the fragmentation of the 24-hour cycle into repetitive sleep-wake, which is very, very irritable, and cause a return to a diurnal pattern, which is sleeping from the evening through to the morning and being awake from the morning to the evening. So it's not rocket science, but by monitoring the sleep of a child, and we have sleep charts, which we give to all families, and they fill out their part for the evening and the weekends, and the children take them to their schools, and the schools fill them out during the day, and we know what the relationship is between the dystonia severity and whether or not they can sit comfortably and whether or not they're sleeping at night. So it's not rocket science, but it's really helpful to prevent disasters. I think I'm going to leave it at that. I had some special videos and cases, but I think that's probably enough.
So thank you very much. It was really beautiful, and I think all the audience, scientists, doctors, and families have really appreciated this very useful and comprehensive talk. So I think we have time for one question, then we can go on with the discussion during lunch. Yes.
So we're going to the last part. So you use clonidine to improve the sleep. So if you're using clonidine for the movement disorder, you will give most of the dosage at nighttime, and how high would you go, or you control it only by blood pressure? And,
So my view is that really, if you know that sleep is disrupted and fragmented, the first thing to do is to restore the sleep. You want the movement pattern during the day to be better, but it won't happen until you get the sleep controlled. So that's the priority first. Once you've got the sleep control, then you can assess to what extent is the motor pattern during the day impaired, to what extent can they sit comfortably for several hours at a stretch, to what extent can they, the moving and handling can be easy. Some of these children, they need 2 or 3 people to hoist them, 2 or 3 people to wash them, 2 or 3 people to dress them, you want to ease all of these things. So it's not so, you focus on the activity patterns rather than on the movement pattern, because the movement pattern is what prevents the activity patterns from happening. So that's what we use, really.
You don't find errors for long-term melatonin as an add-on for this?
Well, a lot of children,
It's to be sold as a continuous sleep kind of inducer.
A lot of children are on long-term medication, but once you've restored the sleep-wake balance, then you can sometimes cut away some of the medicines because the sleep is doing the anti-dystonic work for you. So you can begin to, you then aim to maintain the medication that maintains the nocturnal sleep pattern, but you begin to cut away on the daytime medication so that their alertness and their concentration can actually flourish.
Okay, so thank you very much. So we finished the morning session. Thanks a lot again, all the readers. So lunch, and then we